Hey guys, welcome to this pharmacology drug class review on antiplatelet agents, the P2Y12 inhibitors, also commonly called the ADP inhibitors. In this session, I'm going to explain why the P2Y12 inhibitors matter and make agents like clopidogrel, prasugrel, ticagrelor easy to understand, clinically relevant, and if applicable, even help you to prepare for some of your exams. Now, many people know this drug class for their use in acute coronary syndrome, or ACS, specifically those experiencing STEMI undergoing a PTCA type of procedure, and also its evolution into secondary prevention of stroke. So you're going to encounter them repeatedly in real-world clinical practice, regardless of where you practice. All right, guys. I'm Dr. Busti, and thanks for joining me on This Is Why, a show dedicated in helping healthcare professionals understand the why behind the things that we do, including pharmacology. Because when you understand the why, the how becomes easier, because those mechanisms, guys, start to help us to understand and predict the desired therapeutic effects that we're looking for, but they also help us to explain side effects, contraindications, monitoring parameters, and eventually counseling points. Now, all of this matters for the P2Y12 or ADP inhibitors because they have very unique mechanisms that are influenced by important pharmaceutical characteristics that we're going to talk about. Failing to understand those things that I'm going to cover could truly increase the risk for bad outcomes in the patients who are trusting us. All right, now, as with all the drug class reviews, we need to cover core content. The pharmacology, things like what agents are we talking about, which I've already kind of mentioned, indications and uses. What is the net benefit? Why would I think about this drug class compared to maybe something else, some other antiplatelet drug? And then we'll dive a little deeper into some of that pharmacology, those nuances that I mentioned just a minute ago, that will drive, and orient us around questions, but it also influences the way we counsel patients to take the medication. Also influences things like, when do you stop these drugs if you need to have a surgical procedure? All of that ties back to the pharmacology and some of its pharmacokinetic and dynamic characteristics. So, understanding the why will make sense of that. Then we're going to wrap things up, and we're going to start applying some of that information to the clinical knowledge side of things, okay? Application, and then we'll wrap things up. All right. With that, let's jump into the agents themselves. As you've seen in the way I've done this before, I like to break up the drugs in the way they're oriented for acute care versus the chronic care environment, okay? Because again, depending on where you practice, it may be more relevant to you in one area over another. There's also drugs in this class that we would never use in the outpatient environment. That is cangrelor. That is a parentally administered or IV infusion in the acute phase, basically patients undergoing PTCA, okay? Stent placements and things like that. Now, so what are the agents? Clopidogrel, prasugrel, ticagrelor, okay? Those last three there that I mentioned, not cangrelor, remember it's parenteral. Those last three are orally administered and not available in a parenteral format. Now, ticlopidogrel was kind of the old school, kind of fell out of favor due to side effects, which we'll talk about here in a little bit. TTP in particular is one of those that was a problem. But it's fallen out. Sometimes you can see it in other places in the world, but relatively we're not going to talk much about it because it's the least likely to be used now that we have so many other options. Okay, with that, now that we understand our agents, those that are oral parenteral, let's move into the indications and the uses of these drugs, both in the acute and chronic care. So for those of you on the acute care side, which even if you're on the chronic care side, it matters to know this because your patients get initiated on treatments inside the hospital or acute care and sent home, and following up with you in the clinic and vice versa. You may implement these drugs modify their doses and use in the outpatient or ambulatory care environment, and then we, those of us on the inpatient side, need to consider that and continue the drug or stop it. So that's why it all matters, right? So acute care, we're talking about that acute coronary syndrome, probably a little bit more commonly, especially in the acute setting, STEMI, but can also be used in NSTEMI, especially in patients who cannot or have an allergy or cannot tolerate, take aspirin, for example, okay? So if you have that, this would be an alternative. Chronic is mainly for secondary prevention of acute myocardial infarction or patients with coronary disease who have had an event. That also includes strokes, TIAs, and even peripheral arterial disease. Again, when patients specifically are known to not be able to take common medications that we would use, like things like aspirin. Now, let's pivot back and think about why is this drug class relevant? Okay, what is that net sort of benefit and why we would use this drug class compared to maybe something else? All right, well, first of all, they are considered a first-line antiplatelet agent in patients with post-MI, CVA, PAD, especially those also having arterial thrombosis in other areas like peripheral arterial disease in particular. Why? Because those clots, okay, so if you don't understand all the physiology of thrombus formation, platelets and how they work, a red thrombus versus a white thrombus, I do have a lecture that covers that in the anatomy physiology for that core content, so go watch that if you need a little bit more detail on that. But we know that arterially formed thrombi, okay, tend to have a greater composition of platelets. So therefore, antiplatelet drugs make more sense than using anticoagulants. But it doesn't mean we don't, especially in the acute, use both, okay? But again, many of these indications, conditions where antiplatelet drugs are going to be used are because the composition of the thrombus present is primarily made up of those platelets, okay? Now, the other benefit is having an option where I can give it orally and IV is nice. If I have a patient having a myocardial infarction, many times they can be nauseated and sometimes they're vomiting. I'm not going to push medicines down their throat if that's the case. We need to bypass that situation. And yes, we can use suppositories, yes, less desirable, but having a parenteral drug that we can turn on and turn off has its benefits, okay? And then being able to convert that patient to an oral agent to send them out of the hospital for secondary chronic management of this condition, all of those things are helpful. So you have a first-line agent available multiple dosage forms depending on the acuity of the situation and patient scenarios like nausea, vomiting, but you also then have the ability to use it in the inpatient, outpatient environment. So having those available are helpful, especially if someone has a true aspirin sensitivity where that would be considered a contraindication to its use, okay? All right, now we're going to start to dive in a little bit into that pharmacology, okay? And this is where we're going to start to see a little bit of the confusion. Not going to make it too difficult. I have a couple ways to help you to wrap your mind around it that will make it easier. But don't neglect this piece, especially those of you studying for classes or your board exams and those kind of things. These are great questions. I also use them on rounds all the time, so because they're uniques. But the unique actually has some relevance. It guides us into understanding when we stop the drug for a surgical procedure, or if someone is experiencing a side effect, which these drugs can cause bleeding, then we need to anticipate what is the likelihood of this drug having its influence beyond just this moment, right? How long am I going to have to deal with this? And that kind of translates into that pharmacodynamic kinetic effect, okay? All right, so with that, let's dive into the mechanism of action. There are drugs in here that are reversible inhibitors of the P2Y12 receptor, and I'm going to talk about what that is here in a minute, okay, a little bit more. But we're also going to understand that some of them are reversible versus irreversible, but some of them are also prodrugs, which means that in their main initial structure, they are not in an active form. They have to get metabolized to become active, then do their antagonism or inhibition of that P2Y12 receptor ADP involvement, okay? And so that's important, key. Make sure you recognize that. So you see here that the clopidogrel and prasugrel are irreversible inhibitors of that P2Y12 receptor. That's important. Interestingly, those two agents are also considered prodrugs. They need to be activated. That's huge, okay? So star it, highlight it, underline it, whatever you have to do, and taking a note, you must know that clinically, and it will translate into some things that I'm going to talk about in a minute. Cangrelor, remember the parenterally administered agent, and ticagrelor are reversible inhibitors and really are not prodrugs, okay? Ticagrelor still gets metabolized, but it doesn't require metabolism to become active. Now, why does inhibition of ADP involvement on the P2Y12 receptor, why is it relevant? Because that is the thing that turns on and upregulates the glycoprotein 2B3A receptor. This is just a note again to remind you of that reversibility. So obviously if a drug is irreversible, for the life of that platelet and that receptor, it ain't gonna work, right? It's bound, it's stuck. But the reversible drugs like cangrelor and ticagrelor dissociate off of that receptor. So they're coming on and off. Well, that's good if you're bleeding and you need it to go away, but it's less forgiving if you miss a dose. This also requires more frequent administration of ticagrelor compared to clopidogrel or prasugrel, which are administered less frequent or once a day, okay? So you can see there the mechanism translates into dosing frequency administration issues that may influence the patient's compliance and adherence as well, okay? So that's important, okay? Now those P2Y12 receptors will, change out. Some will get upregulated. Remember the platelet has a lifespan of about 7 to 10 days. So you'll get some new receptors out there that will allow that platelet to work as you stop exposing the patient to the drug if you need to stop it. But that's important. Now, ADP and the P2Y12 receptor. Again, if you need a review on the platelet physiology, please check that lecture out in my anatomy physiology category, okay? Those are also available at thisiswhy.health. But what I'm trying to show you here in this particular image, which is available for free download, and the link we provided to you in the description of the video, if you want that, you want to use it for studying, you want to share it with your friends, colleagues, or you teach, you want to use it, feel free to do so. This is not exhaustive of every potential thing influencing the platelet. It's meant to be a higher level view, okay? All of these components, ADP, collagen, which has some of that von Willebrand's around it, and also interacts with the glycoprotein 1 receptor in particular, epinephrine, platelet activating factor, which is being released by the platelets themselves, serotonin also, thrombin, which comes in part from the coagulation cascade, right? Thromboxane A2, remember that's our target for aspirin, okay? And then of course vasopressin. These are just many of the common things that will turn on and activate a platelet. So there's platelet activation and then there's platelet aggregation. So when you activate a platelet through stimulation of various receptors, and in this case we're talking about ADP over here, binding to and interacting with that P2Y12 receptor, it is stimulating and turning on the upregulation and movement of those glycoprotein 2B3 receptors on the surface. Well, that's the end game no matter what the agonist or activator is. The platelet gets these receptors, and that's what facilitates the aggregation component. So the activation is upregulation of those receptors. The aggregation component is the clumping of those platelets interacting with each other, forming these platelet plugs. Okay, again, typically around a vessel that's damaged, but in this case, where indications we're talking about, where you have an atherosclerotic plaque typically, right? That plaque ruptures, you have exposure of the endothelium, you have exposure of collagen, you have the activation of tissue factor release that turns on the coagulation cascade, and those two merge. And all of those things come together. Now, when you think about the drugs that we administer in acute settings, many times we're targeting multiple of these agents, right? So aspirin, which would target thromboxane A2 over here, is hitting that. We're giving doses and sometimes loading doses, which we'll get to in here in a minute, of clopidogrel. We're trying to stop these platelets from getting turned on too much. Now, obviously, anything in too much, you block all those things, or you totally is shut off, which we have drugs that bind to the glycoprotein 2,3-beta receptors. And again, I have a lecture on that provide you that overview. But if you need to turn it off, then that's the way to do it. You inhibit this particular receptor directly, and it doesn't matter what's turning on the platelet. So we are not stopping all platelet activation or aggregation with only given a P2Y12 inhibitor. Okay? Now, pulling this together in the context of the larger picture of thrombus production. So down here at the bottom is your clot or thrombi or thrombus, right? There are two major contributors to this, right? The coagulation cascade, which is everything pretty much to this area over here to the left, and then to the right in this image is just showing you platelets. The two must be viewed in sync at some level. You cannot only think about them in isolation. Yes, you can learn them in isolation. Many times we teach them in isolation. But I think that is narrow-minded to not consider the influence of how they cross over. So they're both feeding down in here into the clot and thrombus formation. Again, whether it's a white thrombus or red thrombus, or what basically is the composition of that thrombus, is influenced by which of these systems is taking predominance. But what even this image that we have for you here doesn't fully tell all of the story. It's just, again, high-level understanding. But you have also red blood cells that get lumped up inside that thrombus. So again, we have these fibrins, we have platelets, we have red blood cells, and the composition and percentages of those influence that. So we're only targeting one particular input to the activation of platelets that will lead to platelet aggregation issues, right? So we're going to inhibit that. Now, I told you a minute ago that clopidogrel, prasugrel are irreversible inhibitors of that receptor. Okay, so new receptors come, it's blocked, right? Those are also considered prodrugs. That means they require the metabolism through phase 1 metabolic pathways, cytochrome P450 enzymes, to become in their active form. Failing to allow that process to occur can decrease the effectiveness that you think you're giving to the patient. That could be from a drug interaction. It could be from pharmacogenetic polymorphisms, right? Patients with single nucleotide polymorphisms, SNPs, that can cause or lead to the inactivation or even sometimes overactivation of a drug. That's true for other drugs too, that act like prodrugs. So these are important. So clopidogrel uses cytochrome P450 2C19 in particular for its activation. Prasugrel utilizes 2B6 as well as 3A4 in its activation. And then ticagrelor, while it's not a prodrug, still does get metabolized. But it's important to recognize that cangrelor, ticagrelor don't require that functional activation. That is key, right? So you've heard about irreversible versus reversible, prodrugs, non-prodrugs, because those get influenced. Now, I mentioned just a second ago that clopidogrel in particular, which is probably one of the more common historically used P2Y12 receptor antagonists or inhibitors on the market just because of its history. But these are influenced, and its activation is influenced by genetics. So there's a number of different what we call alleles, right? So this area of the chromosome where the gene is expressed for a particular enzyme, right? So most of the time when we say a drug is an enzyme inducer, it's increasing the upregulation and expression of genes to make that protein or that thing, right? Which in this case is an enzyme. So normal metabolizers are that wild type, okay? And that's that asterisk 1 allele, the kind of the normal. Patients who are poor metabolizers, okay, so the enzyme doesn't work or is not available in sufficient quantities. These are patients, and you'll see the designated 2C19 with the asterisk 2 or asterisk 3. That is giving you the indication that there is a genetic polymorphism that has a code. We're not going to dive into the code of where that nucleotide is actually changed from one nucleotide to another, but it's a SNP, okay, S and P really, where there's a single nucleotide polymorphism at that location in the sequence of the gene that translates something different and usually modifies the structure. And the modification of that structure can influence in binding efficiency and potency. And so poor metabolizers will not activate clopidogrel or prasugrel, or in this case, clopidogrel predominantly, right, because it's 2C19, as well. But think about any poor metabolizer of any isoenzyme where that drug is required to go through to become active. That's the concern there. Ultra rapid metabolizers, okay, which is the asterisk there, 17, right, on that allele, those are patients that will more rapidly activate it and could theoretically increase the risk of bleeding. Okay, that's all great. I know, Dr. Busti, you're like, okay, that's fine, but how do I know that? You don't, unless you test them, right? And so point of care genetic testing, genetic polymorphism assessments are gaining more and more use, depending on where you practice, level of comfort, your access to different labs and things like that will influence that. And some people are getting their genotypes done and they're figuring out what their single nucleotide polymorphisms are, and that should guide us, right? It's kind of like getting a CBC or a basic metabolic profile. We just need a baseline on patients, and then once it's part of your profile, well then that genetics doesn't change out throughout your life, right? In the sense of if you have a genetic polymorphism, okay? So you have to kind of think about it, but if you're administering a medication and you don't get the desired effect that you think and expect to receive, you need to ask yourself, well, did the patient take the medication, right? Is the drug in the actual medication? Is it a placebo? Something wrong in the manufacturing process? Very rare. Or does someone have a genetic reason why something like clopidogrel or prasugrel might not work? Okay? And if that's the case, then drugs like ticagrelor become the next best choice because you don't have to worry about that part. But now you got to deal with the reversibility of it. See, that's how it works. I hope that that makes sense. It helps you explain why learning the mechanisms translates into these points that we're getting ready to talk about. So let's dive a little bit more into that clinical knowledge. All right, so first is considering dosing, dosage formulations, timing of administration, these kind of things. STEMI is one of those that is one of the big ones. Okay, I kind of mentioned that earlier on when we were talking about indications and uses and that kind of stuff. And primarily what you want when you're in STEMI, when these patients are getting prepared to go to the cath lab. Now, if you're in a rural environment where you can't get to the cath lab in a timely manner, you may be giving patients thrombolytic or fibrinolytic therapy, and then they still have to get to that place to go to the cath lab. But in the timing, if you do that, influences whether you bolus and the loading dose that is used, okay? But the timing is important because if you're going to administer the orally administered drugs like clopidogrel, prasugrel, well then you want to get that in before the procedure, because when you inflate that balloon or you insert that stent into that atherosclerotic plaqued vessel, you're going to cause disruption of the endothelial wall and you're going to turn on some platelets like you have not seen. That activation of platelets can cause an acute coronary occlusion. So we need the drug at the site of action to exert its therapeutic effect and get activated when that is going to happen. And that's why we load people to increase the concentrations that we need in the body and in order to exert that effect. Now, prasugrel also can be used in the pre-treatment setting. And again, all of them, if you're going to use any of the orals, should be pre-treatment as soon as you can before that procedure. That's ideal. Now, the problem with why some cardiologists, and depending on your area, practice, standards, how you interpret, what are the cardiologists, interventionalists, what do they want, you'll see some variability in this. There are some cardiologists that were like, hands down, do not load the patient like in the emergency department setting. I will decide when we're going to do that based on the thing. Sometimes they do an angiogram first, light up the coronary vessels, see what's going on, where they can they intervene, or does the patient need to go on to having open heart surgery or CABG, okay? And if that's the case, that may influence that, because if you administer these drugs and now they're on board and you do a more invasive surgical procedure like CABG, then the risk of bleeding and prolonged bleeding after that can be part of the bad outcomes. And so in those cases, there are time frames that we want to know. If they're going to go on urgent, on pump, obviously it'd be ideal, okay, these are not absolutes, but there's strong considerations to not use these drugs within 24 hours of that CABG sort of procedure. If they're going to be off pump CABG, right, requires prasugrel to be held for 7 days. Because again, that irreversibility, clopidogrel ideally can take up to 5 days, right? So once you bolus those drugs and they have that mechanism in place, it can influence some of those decisions. Now again, I'm not saying it's an absolute do, don't. It's a moment for pause. And so if I'm in the emergency department where I practice and I have a STEMI and I'm getting ready to send this patient to the cath lab, I will ask that cardiologist who happens to be on call and available, do you want us to load the patient? And they make the decision, because I don't want them to be stuck with a decision that I made and potentially delay definitive treatment to this patient in a situation where they can bolus them on the table. So I will tell you, my experience is that in most cases, the cardiologist does the bolusing on the table. Or we do something like cangrelor, okay, which again is that parenteral formulation. Within appropriate doses in 2 minutes, you can have platelet inhibition. So, right, you're doing that procedure, you start the infusion, you can turn it on and you can turn it off, and the platelet activity, being that it's reversible, comes back within an hour or two. So if you start bleeding or bad outcome or whatever, then that matters, right? That guides you a little bit to that, okay? So that's important to recognize in those uses. If you're going to use cangrelor and loading doses, then and you're going to use the loading doses of clopidogrel, prasugrel, ticagrelor, those kind of situations, then you need to be careful with the timing of that, because you don't want to load them orally and load them parenterally. That's too much. Plus, you could compete with the drugs at the receptor. So if you got one that's an irreversible inhibitor and one that's a reversible or competitive inhibitor, and they're both going to the same receptor, then only so many people can occupy the seat. So the timing of the co-administration of those is typically delayed until the infusion is turned off for obvious reasons. Now, maybe it doesn't matter as much with things like ticagrelor, which is reversible as well anyway, but the point of the matter is just keep that subtle nuance in mind. All right, what about loading doses? This is another one that shows up a lot, kind of confusing. My experience, having practiced in many places in the country, major academic medical centers, I've seen a lot of variability. It has to do with people's interpretation of the evidence, has something to do with the interpretation of the way they practice or trained. All those things influence everything that we do, whether we use low molecular weight heparin drips, those kind of things, right? Those are the nuances of the practice of medicine that we talk about. And there's more than one way to sometimes do something, and it's also based on your gut feeling. But 300 loading dose versus 600 loading dose, a lot of times is really coming down to, like in the situation, are you going to PCI, so percutaneous intervention, right? And is it emergent like in a STEMI, okay? Then let's say no thrombolytic, no fibrinolytic was given, okay? Then typically in that situation, a 600 milligram dose, loading dose to get that concentration up. Because if someone's think about this, if you're using the mouth, right, in the GI tract, and you administer, even at a high loading dose, you still have to get it absorbed, right? It's not like you swallowed it, you do the procedure, and you inflate the balloon 2 minutes later and the drug is there, right? It's not. So we have this sort of dose response curve, if you will, right? The things that we do and the concentration is going to influence that. And so loading doses become relevant. Well, a 300 milligram loading dose may be more utilized, especially if fibrinolytics were administered. So again, that is influenced by the geographic presentation of the patient and then also disposition. If that rural facility doesn't have a cath lab, then they're needing to fly the patient or transport the patient by EMS to another facility. So that just creates a little bit of kind of an adjustment in the way that we use it acutely. Okay, so I just wanted to make sure that you guys recognize that, or at least were exposed to some of those things and some of the evidence behind it. Now, what about as it relates to prasugrel? There's also discussion about the low dose versus high dose, especially in our patients who tend to be older and smaller in weight, where their risk for bleeding is higher. That's true for a lot of drugs, isn't it? Right? We see that with other anticoagulants as well. That same problem occurs. So be considerate of the patient's characteristics. That does guide our therapy. Of course, that's what pharmacotherapy is all about. And so in those higher risk patients, the lower dose of 5 milligrams can sometimes still maintain that preserved efficacy that you're desiring. Okay? All right, now, if you are starting these drugs, one of the things that comes up a lot is, remember, we're using aspirin, especially like a stent, right? So you put a coronary stent in, that's a foreign object inside the body. And many times they're drug-eluting stents because we don't want that endovascularization from the endothelial cells to cover it and then cause stenosis of that vessel. So the stents are impregnated essentially with drugs to prevent the endothelial cells from basically replicating too much, okay? So what we use is dual antiplatelet therapy to protect that stent and that coronary from becoming occluded, okay? Because that can take up to a year, okay, in some patients. Now, the concern there is that you should continue it for at least that long. There are some patients that will go longer than that, okay? So at least 12 months with dual antiplatelet therapy when those patients with a drug-eluting stent, okay? Now, crushed or not crushed in some of these formulations. Well, interestingly, again, some of these patients, let's say they're, had bad outcome and maybe they had a cardiac arrest associated with their MI and they're intubated. Well, then you have to use other forms to get the drug down. You can either obviously try to use the IV, but that's not ideal chronically. We don't do that. We only use it typically in the procedure. But clopidogrel, prasugrel, ticagrelor can be crushed and administered if someone is intubated and put down an oral gastric tube. So just a few little nuances there to keep in mind. Okay, bleeding. We're given an antiplatelet drug. The risk of bleeding is there. Hemorrhage can occur with all of these, right? And you're cannulating an artery, whether it's a radial artery or the femoral artery, to get that wire up there, especially doing the procedure. So those areas can bleed. And I've seen patients present to the emergency department after those procedures or after they go home and discharged, where they're continuing to take these medications and these hematomas start to form, especially if they too much physical activity in that area. So just keep that in mind, that the risk of bleeding is there. Well, that is influenced also again by that patient's age and their body weight. So 75 years of age or greater is that sort of cut off their weight. 60 kilograms, those are smaller patient sizes where the drug exposure can be higher. Now, what about if you're going to surgery? Now, again, this goes back to that mechanism. So your irreversible inhibitors, clopidogrel, prasugrel, you should or ideally may need to wait longer. So clopidogrel is about 5 days, prasugrel is 7 days prior to surgery. Even, no matter what the surgery is, right? You may have to have patients come off. Now, that you have to weigh the risk and benefit of that and their history. And so this is why some patients aren't cleared to go to surgery sometimes, okay? Ticagrelor is different because ticagrelor, being a reversible inhibitor, well, it dissociates. So they have to take it twice a day for that reason. And when you stop it, you can stop it sooner, 24 to 72 hours prior to that procedure. So that can be helpful when you need that desired effect. Well, you don't sometimes know when you need that effect. So if you have somebody has a compliance adherence problem in their history, that's where ticagrelor, even with some of those subtle benefits potentially in that angle, may not be good for the patient, okay? What about acute ischemic stroke, TIA, okay, in particular? Well, ticagrelor, especially with these larger strokes, NIH stroke scores of 5 or more, long-term use in certain population, in high-risk population also is questionable. So just be careful, especially when you are considering those patients for chronic outpatient care. Now, ticagrelor, interestingly, also has a couple other issues with it. One of them is ticagrelor-induced bradycardia. Now, that's thought to occur in part, remember, you're blocking the P2Y12 receptor, and so what ends up happening is the levels of adenosine start to rise, okay? And so this increases and adjusts the uptake into erythrocytes and other things, and has been associated with some adverse events, and this is one of them. So ticagrelor-induced bradycardia would be relevant if the patient's baseline pulse was already close to less than 60 already, or they're on AV nodal blocking drugs like diltiazem, verapamil, maybe even on amiodarone. I mean, remember, these patients already have vascular disease. Their risk for being put on something else or those drugs getting added to an existing regimen is real. So you do not want to ignore this risk, whether you're in the inpatient or outpatient chronic care environment, that you need to be cognizant if a patient's pulse gets too low. Because if they get too low, they start getting lightheaded, dizzy, they're on antiplatelets, probably dual. Well, they fall down, they hit their head. Now their risk for internal bleeding has just gone up, all simply because their pulse got down too low. There's also a risk of dyspnea and sleep apnea, thought to, again, be related to adenosine, but also maybe modulation of this nucleoside transporter 1. It's a sodium-independent equivalent and nucleoside transport 1 here, and increases in adenosine that may augment some of the vagal tone. Don't know exactly for sure. But in this case, it has been something that has been documented or at least alerted to. Now, who's at risk for that? Well, patients who already have obstructive sleep apnea. Patients on CNS altering medications where maybe they become more sedated. We need to be cognizant of that. And so our patients who are older, those who have underlying COPD are much more likely to experience that. Now, guys, there's a lot of other side effects and things out there. I'm just going to mention a few of these last few here, some that are lab mediated, right? One of them is uric acid. So there's several drugs, thiazide diuretics, other diuretics can compete with uric acid levels in the nephron, increase the levels in the body, cause worsening gout conditions. Ticagrelor is one of those drugs, okay? So it's been known to inhibit the reuptake and the transport of uric acid in that proximal renal tubule and potentially worsening gout in that situation. Hypersensitivity reactions, less common urticaria. Many of these cases are also delayed onset, tend to be associated with obviously a rash, and maybe considered in patients with DRESS, GRESS, right? Those are drug reactions with eosinophilia and systemic symptoms as well. So just kind of keep that in mind. The one that kind of pops up, which goes way back to ticlopidogrel, is TTP, thrombotic thrombocytopenic purpura. Very rare, okay? Doesn't happen very often. And even though it's been listed, there's been some case report issues, maybe some warnings in the product package insert for clopidogrel and other drugs. Again, these cases are pretty rare, and they usually occur within 2 weeks and those patients then need typically plasmapheresis. Why does that happen? Not entirely sure, but it's thought to be related to decrease in Adams 13 levels in some form or fashion due to antibody production. I'm not going to dive into platelet disorders in this lecture here and Adams 13 and all that, but there's a lot of things. Like, again, I'm only exposing you to the basics here, but recognize that this is one of the reasons why when we do laboratory monitoring, the CBC is part of that. It's not only for trending hemoglobin for the risk of bleeding, right? These patients are at risk for hemorrhage and bleeding, but it's also looking at those platelets and the functionality of those platelets. But patients will start to manifest symptoms systemically as a result of TTP. Again, mainly associated with ticlopidogrel, which is no longer used in the United States. And of course, uric acid levels may go up, especially if patients have a history of known hyperuricemia or history of gout. This can be very relevant for them. All right, special population considerations. Geriatrics. We've already alluded to that earlier when we were talking about patients who are 75 years and older. They tend to also be smaller, okay, in size. Many times as they get older, they start losing weight, start having more side effects of medications, and their risks go up because of the number of medications, including the use of other medications that increase the risk of bleeding themselves. But remember, once you get that low body weight, old or not, the risk of bleeding goes up, especially with prasugrel in particular. Okay, now wrapping things up, okay? So these agents in the P2Y12 inhibitors representative cangrelor is your parenteral, clopidogrel, prasugrel, irreversible Prodrugs, ticagrelor, reversible, okay? Indications, acute coronary syndrome, many times can be an alternative if you have aspirin sensitivity. We also use it in secondary prevention of stroke and patients with peripheral arterial disease, okay? Mechanisms we talked about already, but remember they're activating, it's preventing the activation of those platelets that will lead to the upregulation of the glycoprotein 2B3 receptors that cause platelet aggregation. So it's kind of indirectly in doing that. So obviously our risk of bleeding is high. It's relevant. Now don't forget, bradycardia, dyspnea, sleep apnea with ticagrelor in particular, okay? That's key. But remember, that mechanism drives frequency of administration. It also drives the issues related to compliance and the timing that we should stop around a procedure. And those reversible inhibitors are going to allow us a little bit easier transition, but you gotta be more compliant. All right, guys, I hope that you found that review on the P2Y12 receptors ADP inhibitors relevant. If you've already learned some of that stuff, maybe it was a good review. Hopefully you picked up a few little pearls, some little nuances, some things that are higher, more yield than others. If you haven't subscribed to my YouTube channel, please do that so you can keep up to date on other topics that we're putting out. There's also other lectures related to this that can build on that foundation, okay, guys? I'm Dr. Busti, and I really appreciate you joining me on this episode and investing in your own knowledge base. The goal here is for us to learn why we do what we do, because it makes the how and way we manage patients much easier. All right, take care, guys.